So like she said, my name's Dana Patrick, and I'm the director of the pediatric ICU and the pediatric transport team. I have to say we have child life specialists assigned to every unit in the hospital, in addition to having assigned in the emergency department, and they now come into our trauma rooms as well. So it's pretty awesome. We love them. So anyway. So I just wanted to kind of give you a little bit, mainly I'm going to answer any questions that you have about CHET, but I wanted to kind of give you a little information about our transport team, just things that I think a lot of people get confused or don't know about. So I've been at Rady Children's for a really long time. You have to keep in mind I started when I was like 9 and I've been there 30 years. I was actually on the transport team and did transport for about 25 years. Before I went into the director of the PICU. So it really is, transport is really my first love. I love doing pediatric transport. So one of the things, I go a lot of places with my son. He's a mountain biker and he does a lot of competitions and stuff, and I always wear my CHET t-shirts. And several times I've had people come up to me and say, who is CHET? So it's like, it's not a person. So I just wanted, CHET was, we actually came up with the name 100 years ago when we were just Children's Hospital before we were Rady. So it just stands for Children's Hospital Emergency Transport. And when we started, like I said, almost 100 years ago, in the 70s, we were doing probably one or two, I wasn't there then, but we were doing one or two transports a week. Usually was all it was, and I think they were doing less than 20 in a year, usually. So today, our transport team, when people see us in the community, they just think it's all one team, but we actually have two separate teams. So we have our neonatal team, which goes to delivery room, or goes to neonatal ICUs, and will also respond to deliveries. And then everything else our peds team usually does. The NICU team will also do what we call return transport, so they'll take babies back to the hospital where they were born once they get stable. Our peds team then will take care of any kid that's 1 day old up to 30 years old, so pretty much whoever we're called to. We don't do any scene responses. We only go to clinics, emergency departments, go to peds floors, community hospitals. Oops. So our team is actually in-house 24 hours a day. Our hours change from time to time, but basically what you guys need to know is that we have somebody there 24/7. For the peds team, we actually have two teams in-house for 12 hours a day and one team that's there 24 hours a day. And we vary our backup team hours frequently, depending on what we need. We can add a pediatric ICU nurse practitioner or a critical care fellow to the team. And we can usually do that 24 hours a day. There's somebody that we can add to them. So the reason I put this slide in here was a lot of times, because our team isn't a scene response, we don't get out the door, immediately. We have to get some information, which I'm going to show you in a little bit. But one of the things we like to tell our referring facilities is it's not necessarily how long it takes us to get the child back to Children's, but it's how long it takes us to actually get to the child. Because our team can deliver pediatric intensive care on site. And so that's one of the things that we really stress is it's really important to get our team there fast versus trying to get them back here fast. Some of the things that our teams can do, we function under standardized procedures and protocols, but one of the advantages to our team versus like a Mercier or REACH team or something like that is that we actually are in constant contact with our ICU attending on the really sick kids or medical control officer on the less acute kids. So our teams have some standardized procedures that they can do without orders or without talking to a doctor, but we can do pretty much anything once we are in contact with our physician. So all of on the peds team, our teams are completely cross-trained. So a lot of times you'll see our respiratory therapists are starting the lines, the nurses are intubating. They're like I said, completely cross-trained, so we share all the responsibilities. Where we usually go, we do a lot in San Diego County, Imperial County, Southern Riverside County is one of our big referral areas. Occasionally, when we're lucky, we get to go to Hawaii. We've gone to Saipan. It varies. A lot of times Hawaii has a really good transport team at Kapiolani, but from time to time they don't have people available, and so we get to go over and pick up kids, so it's kind of nice. Because you know, when you go over, the pilot has to rest for 8 hours, so you get to stay overnight when you're picking up a kid, so it's kind of nice. And then, like I said, most of our kids are in emergency rooms, doctor's offices, clinics. The only place that we go where we're really outside is we'll do a switch of patients at the border. So a lot of times we will meet a Mexican ambulance at the border and switch off kids there, which is a little bit scary when we've got intubated kids that you're trying to get report and you don't speak Spanish and they don't speak English, and it's kind of challenging sometimes. I just kind of wanted to give you a little idea of how many transports we do. Between the two teams, we do about close to 2,000 a year, about 1,900. And when you add in the return transports that our neonatal team does, we're over 2,000 a year between the two teams. Just to show you kind of what our most common diagnoses are, respiratory is by far the most common one that we have, and we just lump them into categories. But in the winters, the respiratory ones are bronchiolitis, a lot of RSV that we get. So those are the most common diagnoses that we see. And then our mode of transport is, the majority of the time that you'll see us here is by ground, although we do have the ability to take a helicopter if we need to get there in a hurry. But kind of our general rule of thumb is if it's going to be longer than 45 minutes by ground, we take the helicopter. So ground is usually less than 45 minutes. So that means we take into consideration all the peak traffic times as well. We do have a fixed wing available to us, and we are contracted with them to go any place over 100 miles. We take the fixed wing unless there's something with the kid that warrants us going rooftop to rooftop. So this is usually we're going out to El Centro or Brawley or Blythe this way. And they actually have 2 planes dedicated for us at Montgomery Field, and we can get on the plane in 30 minutes time. This is our favorite mode of transport, is the helicopter, and we actually are contracted with Mercy Air. They have co-branded, I'm sure you've seen the helicopter, they have co-branded a helicopter for us, and they have it available to us. They are based at Montgomery Field, but they will fly over to the hospital and pick us up on rooftop, and we usually need about 15 minutes and then we can be out the door with Mercy Air. They do have backup helicopters for us available, so if the neonatal team is out with one of the helicopters, they can get another helicopter for us pretty quick. So, and we actually function on Mercy Air, we function as crew members, so they just send a pilot. So we go through all the same training as their crew members. When we're not out on transport, we do a lot of things in the hospital, and there are a lot of fun parts to being on the transport team as well. But in the hospital, our transport team are the Code Blue responders, rapid response responders. They are the nurses on the transport team are the team leaders in traumas. So all of them go through, they have to be TNCC and meet all the same criteria as you guys do for traumas. They are backup for the ICUs. So for PICU and CVICU, if a kid's coding or you've got a really sick kid, the transport team will be there to help out. And then one of the things that's kind of evolved over the years is we used to just occasionally go out and start an IV whenever people would say, oh, I can't get this one. Well, people have gotten so used to us starting IVs, and their families are getting so used to us starting IVs that if we have return customers, they will call and say, I want the person in the blue suit to come and start the IV. So we've kind of become the IV expert team in the hospital, and we do over 150 a month just in difficult IV starts throughout the hospital. And so we're trying to do some education or re-education of nurses out on the floors about IV starts, because in the winter months we're really busy and they just doing transports, and so the kids will have to wait for a long time for their IVs. So that's one of the things we're trying to re-educate nurses about. We do disaster response, do a lot of disaster practice scenarios, that kind of stuff. And then we get to do a lot of public and community outreach. And our teams will go to elementary schools a lot. They're available if you guys have kids in elementary schools and you want the team to come out and just, what we do is a lot of times it's our team's kids or somebody in the unit's kids. We go to elementary schools, give them a little talk about safety, bicycle safety, and let them go through the ambulance. And it's usually very well received by the community. And then we do a lot of PR events. Whatever we do stuff with Mercy Air, we do stuff with AMR. There's a community event called Touch a Truck that we actually take the helicopter and the ambulance to, and it's for kids in the community. And they bring fire trucks and all kinds of different trucks out in the community. So it's kind of a cool event that we get to do. So when you call for a CHET, we have gotten feedback that the names that we use for people sometimes is a little different than what a lot of places are used to. So we have several different people that are involved with our transports, and I'm going to show you kind of the whole activation process in a minute, but basically we have a medical control physician. We call them our CHET coordinators, and they're usually a hospitalist that works in our hospital, and they will take CHET call. And so that is our medical control physician, and they're the ones that will talk to your physician here. So all of our kids have to have a receiving or accepting physician communicate with the sending physician before we can take them. Our referring physician is whoever is requesting the transport, and then our accepting, like I said, is the CHET coordinator, unless they're going to the ICUs or unless they're a trauma. So if they go to the ICUs, the PICU attending or the CVICU attending will be the accepting. And then for all traumas, our trauma surgeon has to actually talk to the referring facility. And so the trauma surgeon is the accepting physician. Our PICU attending actually functions as a medical control officer for us anytime there's a kid that's going to the ICU. So we are able to get ICU advice. Like I said, the other CHET coordinators are medical control physicians or hospitalists, so they're general pediatricians for the hospital. So they're not able to really do the ICU advice piece. Same with the CVICU attending. And then, like I said, we have a CHET, RN, and RT on every transport, and they're completely cross-trained, so they're able to be interchanged. We never go RN, RN, or RT, RT. It's always one of each. And we call them our ALS team, which I know is a little different than what out in the field people refer to ALS, but this is what our team is. And then when we add an MD or an NP, like I said, they're critical care PICU trained NPs or physicians. Our team, it used to be kind of our rule of thumb to send an NP or a physician anytime the kid was going to an ICU. We would add the physician or the nurse practitioner, and we don't do that much anymore. In fact, we used to go about 20% of the time we always had a physician or a nurse practitioner, and now we're down to less than 10% of the time we're sending a physician or nurse practitioner. And then we have a house supervisor that has to be involved in this whole process just to help us get the kid where they need to be in the hospital. I kind of talked about this already, just what our team composition is, and we will refer to it as a full team when we send a physician or a nurse practitioner. Our response times, and I put this in here because this is, once activated, this is what our response time should be. And there's a pretty big process to us getting activated, and we have tried to really cut this down so that it's as efficient as can be. But basically, once we're activated, we want to get out the door as quick as possible. So we can do 10 minutes on ground because we actually have an EMT that stays in an apartment really close to the hospital, and it takes them 10 minutes once we call them to get from their apartment to the hospital. And they do like 24-hour shifts, so they're there. So our EMTs are quick, so we get 10 minutes or less, we can get out the door on by ground. Helicopter, it takes a few minutes, and like I said, the fixed wing, our pilot gets there in about 30 minutes. So this, you don't have to read all of it, but basically is our activation process. And what we have contracted with an agency to dispatch our team. And so they will, when somebody calls for a CHET, and I have the phone number and everything for you, but when somebody calls for a CHET, what happens is it goes to this dispatch. And then they will immediately, while they're talking to the person on the phone, taking the information, they will start paging the team and page the physician that's going to be accepting. And then once they get the information and the physician calls back, they connect everybody on a bridge line. So sometimes when your physician will call, we will get their number and tell them that somebody will call them right back. So I think that it's a little frustrating at times for people because it's not like, I need to get this kid out of here right now, right this minute. And it doesn't go that quick all the time. So the information that we need immediately, though, if you have it, is we try to get the name, date of birth. We always want to know a phone number where the physician can be reached to call back. And then just the location that the kid is. We used to dispatch out of the ICU, and the charge nurses would get a call from a referring facility that was like way out somewhere in the boonies, and they would call like there's a kid coding and they really need us there quick, and they would not give us any of the information. They would just say, I need the CHET team here in a hurry, and then they would hang up. And the charge nurse is like, I don't know where they called from, I don't know what to do. So we always try to we used to give little notepads that had all the information that we need, but basically we just need the name, age of the kid, and where they can call the physician. So they go through all this process. So it actually takes about 10 minutes to have the kid accepted before the team is actually activated. So even though we say we're out the door in about 10 minutes, that's after that activation. So it's at least 20 minutes before the team will get out the door. So that means getting a team here, you're probably 30 minutes at least from the time that you initially called until we actually come across your door. We do have some, I call these special transports because they're not activated in the same way. They're just a little bit different. And trauma is one of those. This picture down here on the left-hand corner, this is actually our CEO, Dr. Donald Kearns. He got to fly with the CHET team, and he was just so thrilled. So we got to put him on the helicopter. So trauma patients. So our dispatch will get a call, and they know if it's a fall, if it's a MVA, something like that, they know that that's a trauma, or if they tell them it's a trauma in the diagnosis. And the biggest thing that we stress with them is that the trauma surgeon has to be involved in this conversation whenever it's a trauma. And so they will, usually when our CHET coordinator gets on the phone, they will ask the physician, has the trauma surgeon, have you had communication with the trauma surgeon? If not, we can connect them. What happens sometimes is they just bypass our medical control physician then and call the trauma surgeon, which we're trying to educate our trauma surgeons more about how important it is to involve that control physician, because sometimes they don't get activated as efficiently if the trauma surgeon tries to activate the team. So we're working on that piece of it. But basically, they put everybody together on a bridge line so that everybody can listen to the report one time and know what's going on with the kid. And then when we transport trauma kids, we can do a direct admission to the ICU, or they go to the emergency department. Usually like if Reach or Mercy Air or another ambulance company will bring a patient in, they have to go through the emergency department. But we can do direct admissions to the ICU depending on what's going on. One of the things for you guys to know is you can report directly to the transport team, and then they will do the handoff once they get back to Rady's. Frequently we have people call and they want to give report direct to a nurse, but it's fine. Just give report to the transport team and they can pass it on. Some of the things that we need, and I understand there was some confusion recently about exactly what it was that we were asking for. And really we need pretty much standard, I think, what you gather for all transfers or transports out of your emergency department. But one of the things that we need is we need the films, like if you had CT scans or anything like that, get that on a disc or some type of digital way for us to read it at Rady's. And then if we can get a printout of the interpretation of what that test was, so that our radiologist can compare to what your radiologists have said. And then we need copies of all the lab tests, anything that you've done, or if something's pending, if we can just get a phone number to where we could call back and get those results. If you guys have questions, please. Yeah, you look like you had a question.
Regarding this, because we recently had 2 pediatric patients that came with mom, and they were to be transferred over to children's, and all of a sudden it was medics, it was first responder people that showed up to take them.
Huh.
And they both went over to children's. And the problem was, it was like we almost had to force them to take report.
Oh, wow.
And, we'd already done workups, and we had vitals, and we had all this. So I don't know what happened with that, because I know that the physician was on the phone talking, so I don't know why all of a sudden we had first responders there versus CHET.
Huh. And your physician was in the process of activating CHET?
As far as I know, yeah.
Yeah, I'm not sure why they would do that.
Because then the thing was, is we had also understood that children's or Rady's can look at the x-rays and whatever that we've done. Is that correct?
That is correct, and we want
So
to.
we didn't send that.
Oh, you mean look at through your system?
Yeah.
I don't know the answer to that, actually. we always ask them to send us a copy.
Yeah. So I don't know if maybe that that CHET was busy with other things. I mean, I don't know, but that's not normal, right?
It's not normal. It's not normal. And we do have the ability to get another team. Sometimes if the physician doesn't want to wait, like we say, well, our primary team is, out in El Centro, we can send you a backup team, but it'll be 30 minutes or whatever. Sometimes they may not want to wait. I don't know why they would activate first responders, because that usually is like a 911 call or something to get them there. So,
No, they took their baby first, or the 2.5-year-old first, because I know it was totally crazy now.
Yeah, and that's one of the things that we always say, because the first responders really aren't going to do much but just transport them. Where we can, if they need some type of care or therapy implemented right away, we can do that on site. So, and you guys are close, so especially going by ground, we can usually get here fairly quick. And we have instructed our teams and our dispatch and everybody else, if we were to get a call that says CPR in progress or something like that, they don't go through that whole big process. We get the team out the door while the phone calls are happening. So, the other thing that we need on traumas is if the C-spine has been cleared, sometimes our trauma surgeon will direct us to go ahead and put them back in C-spine precautions, which is very annoying for our team, just to let you know, but we will do whatever our trauma surgeon's telling us to do. But I know we've gone to pick up kids that mom's sitting there holding them in the lap, and we're like, oh, we gotta put them back down and put them in precautions. So that gets a little frustrating sometimes. But we just need to know who cleared the C-spine, what's the name of the physician, and what's their specialty. That way we can tell our trauma surgeon, this trauma surgeon here cleared them. So, and then the transfer paperwork is pretty much like you do for any typical transfers. We just need flow sheets, nursing notes, face sheet, any kind of documentation that you had on the kid here. And then really important is a phone number to talk to the specific people who took care of the kid. So if it's in the emergency department, the physician's name, or if it's a nurse that was really involved in the case and you're going to be here a little bit, you can give them that phone number as well.
We just had a patient come in recently that had started children's, and when the CHET team arrived, they were asking for the consent because of EMTALA, that he has to go from one outpatient facility to another for the consent. And so is that something that by EMTALA rules we always have to provide for you?
We have our own consents for transport, so I'm not exactly sure why they asked for that. We do ask that there is a note, and this is 50-50 that we get it, that there's a note by the physician saying why they need specialty services, like this needs to go to a pediatric specialty place. A lot of times the physician just writes that in their note, but it's not a consent. It's just they can write that in their note.
So per EMTALA laws or rules, we don't have to consent the family and tell them the risks and benefits of transporting a pediatric patient to your facility?
Well, we usually do that on arrival when we talk with them, and they sign our transport consent. So,
So you're the one who actually has that?
We have, and it's not an EMTALA consent, it's just a consent for transfer. So, and transport, and we talk to them about, risk of transfer, so if we're going to fly the kid or whatever. So I did hear about that. Stephanie was telling me about that they were asking.
That was the thing, is that we, it sounds like your transport consent does everything that are by EMTALA rules that we have to provide. We just didn't know if we had to do the consent, or since your transport team said, the guy's like, oh yeah, did you get the consent? And he wasn't upset about it, but he was like, oh, then I'll just go and consent the family in court. So that was the consent he used. So I think that answers our question.
Yeah.
Your transport.
Yeah, we have our own transport consent. So yeah, I'm not sure why they were asking that, but we do have a couple of people on our transport team that do other transport jobs, and so they may have a different response when they're with their, on their other transport jobs, or maybe it was something that they needed to do. Also, our physicians and nurse practitioners don't go on very many transports, and so sometimes, we educate them, we orient them and all that, but I always think, oh, you don't do it a lot, are you comfortable with this? So, yeah. Any other things about what we need for transfer? It's pretty standard, I think, information that we ask for with transfers.
I think a lot, if you're talking 20, 30 minutes, sometimes we can't get all that stuff
Right.
that quickly, so just whatever you can get,
Yeah, I tell you what's really important is any films or imaging that you did, if we can get those, and I know that sometimes takes a little bit, but that way we don't have to expose the kid to more, x-rays or whatever. But if you can't get it, we use very low radiation in our CT scanner. It's like the minimal that you can use and get good quality. And so it's, I don't want to say it's not that big a deal, because I'm sure it is to the family and the kids, but it really isn't. I mean, a lot of times we repeat scans anyway because the quality of the other referring wasn't the same. So, especially when we go way out in the boonies somewhere. Another transport that we do, and we actually do a lot like to the Morris Cancer Center or some of this, is we have what we call prearranged transport. So this is anytime you can plan it. So if you can plan for transport to happen, we do a lot of those, and well, not a lot, we do a fair amount that we have to get insurance clearance before we can do these. We don't have to get insurance authorization for anything else. All of the emergent transports we do, even if it's a kid that was sitting in an emergency department, a ways away and they've been there for a couple hours, we can still do that as an emergent transport and not have to get insurance authorization prior to that. The only time we have to do it is if we're planning the transport ahead of time. Then we have to get insurance authorization. And one of the things that I run into a fair amount is that I will have a parent or somebody call me and say, AMR isn't on my insurance plan, and now I'm getting a bill, my insurance won't pay it, what's up? And the deal is, and all I do is I talk to either the case manager or I'll give the insurance company a call and talk to them. The only way you get CHET is, if you're going by ground, is with AMR. We don't use any other ambulance company. The only way you get us by helicopter is with Mercy Air. And those two companies actually do the billing for us. So the families will receive a bill from AMR or from Air Methods, but it's for our transport team. So once I usually talk to the insurance companies and explain it to them, it's not a problem. But the family sometimes get a little stressed out about that. They're like, oh, AMR is not on my plan, but because it's a specialty transport. That's why it also helps when they document in the physician documents in the note that they need the specialty pediatric team. We also do this other transport, let me just go backwards, sorry, that we call CHETs, and it's a long story why it has that name, but basically it's when we transport patients that don't have anything to do with our hospital. So we do a lot for the Navy. We'll go from Camp Pendleton to Balboa. Sometimes we'll go from Southern Riverside County Emergency Department to Kaiser, if Kaiser's team isn't available. So we do what we call interfacility transports that don't involve Rady's, and we're happy to do that, and it's not a problem for us at all. So here's how you get a hold of us, and I actually have put some reference cards. We have these trifold reference cards, and I saw you guys had Broslo tapes and vital sign information, but we have all that on our little trifold cards as well. Not the Broslo information, but we have regular vital signs. And then inside is a list of the medications that we frequently see given and the doses that we use. It's just a nice reference card to have for pediatrics. It talks about ET tube size and the length and how you calculate where you put the ET tube, normal vital signs, what they should weigh at certain ages. So it's just kind of a helpful little reference card. In fact, a lot of our physicians and residents that come through will use our CHET cards. We have two different lines for the different teams. And like I said, our peds team uses a different dispatch than the neonatal one. The neonatal team actually rings to the neonatologist, so it'll go right into their NICU. And the peds team will go through our dispatch. Any questions about the information that I